Gwen Krieger. I'm the nutritionist at Heart Wellness, and February is Heart Health Month, so I'm here to interview David Lerner. He's an acupuncturist and herbalist with training in functional medicine, which he utilizes in conjunction with the doctors at the clinic. And we also have Tim Shannon here. He's a naturopath at our clinic who specializes in homeopathy. And we're going to discuss how we approach heart disease and prevention of heart disease at the clinic. A couple facts that you may not know is heart disease is the #1 killer of Americans. 1 in 4 deaths in America are due to heart disease. It's a silent killer. Many people who have a heart attack never had any warning signs that they were at risk of a heart attack. And the other thing that's very important to note is the cost to our healthcare system and to us as a country. Heart disease alone costs the United States $108.9 billion per year. That includes the cost of healthcare, medications, and loss of productivity. So we're going to dive right in. And the message that the media and conventional medical doctors strongly give us is that we have to aggressively lower LDL cholesterol. What are your thoughts on that?
Well, I think LDL cholesterol is obviously a big player. It's an inflammatory particle that definitely has correlation with cardiovascular risk. But in isolation, if it's the only thing you do, you're not necessarily protecting people as much as you can. Like as an example, I have a patient, and this is not all the time, but I have several patients that when I run a cardiovascular panel on them, some of the patients, you notice their cholesterol is normal, their triglycerides are normal, their non-HDL cholesterol is normal, and their HDL looks great, which is those are all the components of a standard lipid panel. But the panel that we run here also runs a whole range of other cardiovascular markers that have just as much, if not more, scientific backing in terms of predicting cardiovascular risk or the event or possibility of a cardiovascular event. And in one patient, one of the recent patients I had, everything in the normal lipid panel was normal. They were all in good ranges. But everything below that, the Lp(a), which we're going to talk more about, the Lp(PLA2), his HDL particles were way lower than they should be. His ApoA was also way lower than it should be, and his ApoB, which we'll talk about as well, was also elevated. But if all you run is a standard cholesterol panel, you'll never even see any of those other markers. So in our goal, it's not just the LDL particles, but there's so many other lipoproteins and lipoparticles that we have to address, and we have to be able to determine them. And if you don't run the full panel like we do here, then you're not going to even know that some of those are a problem or not.
The analogy that I like to use is that cholesterol are like the passengers and the particles are like the automobiles or cars. And cholesterol, which is fat soluble, has to go through the bloodstream, and which is water soluble, so it has to be in these carriers. And so when we're talking about the particle sizes, we're thinking about the cars, and we want bigger cars and we want less on the road. So you can have a normal LDL, but if it's carried in a lot of particles, you have a large particle number, which is a bigger risk factor for coronary artery disease. And then we're also looking at the size of the particles. Are they big and fluffy, or are they small and dense? The big fluffy ones aren't as big of a problem. So we want people to be traveling in buses, basically. We want the cholesterol to be, no matter how much cholesterol we have, we want them in buses. We want a lot of the cholesterol in large vehicles, because that can't get into the arterial lining. If you have less vehicles on the road, you have less chance of getting into an accident.
Correct. So just to recap, if I go to my normal allopathic doctor and I get the typical blood panel for assessing heart disease risk, they're going to do just my LDL and my triglycerides, HDL, total cholesterol, which might look great, but I could still be at serious risk of heart disease.
Absolutely.
And here, we go further and test those other markers that have great scientific backing, better predictors of whether you have on the road to heart disease or not.
Well, I think the argument is that why not use all the tools we have to measure for the risk, since it's such a big killer. And then one of the other things that we have here too is we're doing ultrasound Doppler of the carotids as well. So for people that have a family history, that have many of these inflammatory markers are elevated, and they're sedentary and maybe they're carrying some extra weight, we're going to pretty much refer them over to get the ultrasound of the carotids to see if there's any evidence of disease that's already extant. So we try to use as many tools as we can and employ as many metrics as we can to not only determine the level of risk that the patient is at now, but also post-treatment. So in other words, we set a baseline for the patient and then describe with them what their risk factors are. Then we set them up on a treatment plan, and then we use those same metrics again to measure to make sure that those numbers are improving and their risks are going down. So that's in a nutshell the kind of the treatment approach that most of the providers use here.
Yeah, and I just want to add, it's not just the LDL and the cholesterol that are the big players in terms of someone having a plaque in their arteries and a plaque that ruptures.
Right.
But there's other more important issues to some degree, which is how much inflammation is in the area, how much oxidation is in the area. So LDL by itself isn't necessarily a bad thing. LDL is necessary for life. The concept that cholesterol and LDL is evil isn't really true. But if LDL is small and dense, if LDL becomes oxidized, if LDL burrows into the arterial wall, then you create, you're setting yourself up for getting a plaque, and a plaque that potentially can rupture, and that can cause an incident, myocardial infarction or heart attack.
Okay.
And so there's one other piece in there is that when you asked about aggressive LDL lowering, right, or aggressive cholesterol lowering, there's a lot of patients that come in, they've been on statins for a long period of time, and their LDL is so low that you'll see the side effect that nobody really ever talks about, and that is that their testosterone is really low. And many of their other sex hormones are low. And what people don't realize is that cholesterol is something that your liver manufactures, and it's the substrate, i.e. the beginning material that your body then develops hormones from. And if you drop your cholesterol too low, which happens all the time. I mean, so many patients who are on statins, they come in and their doctor says, wow, your cholesterol is so low. And I look at it and I'm like, well, what are you going to make your steroid hormones from? And when I run their hormones, I can see that they're all low. So it's not so simple as just change one number. It has many more effects.
And I agree with that, because what I like when we talk about even looking at our bodies functionally is one system, your cardiovascular system, is not separate from your other systems. So when you're affecting your cardiovascular, it's going to affect your digestion, it's going to affect your endocrine system. They all interact together to make up the whole. And that's why I appreciate that we look at those things. Whereas if you go to your regular doctor, they aren't. They're not going to look at that. So I appreciate that. Okay, so how important is it, or we talked about LPA, you mentioned LPA. So can you just describe that a little bit, and then why it's an important risk factor to look at?
Yeah. So lipoprotein little a is a specific lipoprotein that is pretty much genetic. It's not, you get it from your parents. It's not affected by diet at all. And it's a very atherogenic lipoprotein. It's an independent risk factor for cardiovascular disease just by itself. So all your other lipids can look great, everything can look great. If you've got an elevated lipoprotein little a, that's a big concern. And the reason why it's a big concern is because it's shaped like a little corkscrew, and it can actually burrow itself into the arterial wall and cause all sorts of problems and oxidize very, very easily. I think the reason we don't hear about it much in the conventional press, and why conventional medical doctors and even cardiologists don't look for it that much, is because we don't actually have a drug that treats it. We can indirectly treat it by lowering LDL, because part of LDL is made up by lipoprotein little a, but that's very indirect. The things that treat it best are niacin, which is a nutritional supplement, In men, sometimes testosterone. In women, estrogen, DHEA, fish oil. Oftentimes you have to use really high doses of fish oil, up to 6 grams a day. So it's definitely something we test for it when we do the advanced lipid panels. And I think it's something very important that everybody needs to get a baseline done on to find out if it's elevated, and it should be treated aggressively.
Okay, so that would be my question as just a normal person who doesn't know all the ins and outs of this. So if I come in and I have my LP(a) tested and it's elevated, and then you put me on a niacin or whatever, the fish oil protocol, you're going to retest me, and I can see the efficacy of what we're doing.
Totally.
And it will reduce.
Right.
And if not, then you'll
shift gears.
You'll shift gears. Okay, I think that's important for people to know. Okay, so how important is it to assess triglycerides? We hear a lot about elevated triglycerides. What are your thoughts on addressing triglycerides?
Well, triglycerides are again another risk factor for cardiovascular disease, and triglycerides are another way of saying blood fats. So that's, there's triglycerides that we have to look for. There's something called LP(PLA2), which again is a real-time look at whether or not there's already plaque development extant in the vessels. So again, along that with the ultrasound Doppler is one of our best ways to guard against whether or not people already have development of atherosclerosis, which is development of plaque inside the lining of the vessels. Triglycerides is one that's crucial, and then the other one are the 2 helper cholesterol particles. One is called HDL, and the other one is ApoA1. So you also want to be able to quantify those numbers to see whether or not the helpful cholesterols are also in a high enough protective range. So those are some. There's other ones that we want to look at too.
I think triglycerides is a really, really important marker to run. It's of the basic 4 that's run in a conventional panel. I think by far triglycerides are the most important. And the reason why that is because they show up in all the different sorts of lipids, A, and B, because they're upstream from the small, dense lipid particles. So all the small, dense lipid particles come from triglycerides. So again, we distinguish between big, large, fluffy particles, which are less problematic and less likely to get into the artery, versus the small, dense LDL, which are much more problematic, and those all come from triglycerides. So one surrogate marker for looking at the small, dense LDLs is really assessing triglycerides. The other important thing with triglycerides is it's a good indication for metabolic syndrome. So we like to see triglycerides ideally around 60, optimally under 100, and the reference range is under 150, but we like to see them lower than that. And it's also a good indication of, like what I said, metabolic syndrome or insulin resistance, or how we're handling sugar.
Okay, so I want to ask you 2 questions, because you use the term metabolic syndrome. Maybe people don't know what metabolic syndrome is. So just a quick definition of what is metabolic syndrome and why is it important to care if you have it. And my second question, which one of you can answer, is what causes triglycerides to elevate? Is it eating fat, and that's why people should eat low fat, or is that incorrect and there's another reason for elevated triglycerides? So go ahead and take.
So metabolic syndrome is a synonym for insulin resistance. And so when the body has a range of blood sugar that genetically we're acclimated to be able to use in an appropriate way. Because blood sugar is something we use for energy and to do work in cells. But once blood sugar gets too high, the body has multiple safety mechanisms, because excess blood sugar is inflammatory in nature. It can cause damage and destruction to various tissues, to the eyes and to the nerves and so on. And so what the body does is it stimulates insulin excretion from the pancreas, and that insulin then takes that excess glucose and stores it in cells as fat. And now, if this happens occasionally, what ends up happening is, if the blood sugar is here and somebody has, let's say, a high carbohydrate dinner or something, and their blood sugar elevates up to a higher than normal range, the insulin is used to store some of that, and then the blood sugar drops back down into a good range. But if a patient is in a phenomena or into a lifestyle where their blood sugar is always elevated, that means your insulin levels are also always elevated. And in that process, eventually that blood sugar is trying to be stored by insulin and trying to pass through those cell membranes, and be stored. But now those cells are starting to become saturated. And once they become overly saturated, that's synonymous with the term insulin resistance, because the insulin has to go higher and higher to try to force that blood sugar in there. And so that's what we're talking about with insulin resistance.
So I kind of like visuals. So for me, it's like, you know, think of blood sugar as fuel for your car. It's the gasoline. And if you fill the car and you're not exerting enough energy or traveling enough in your car to eat up the gas, then you're just, your gas is pouring out of your gas tank, correct?
Sure.
And,
I mean,
and in pouring out of the gas tank, it's doing bad things for you in a physiological way. It's creating metabolic syndrome, which is dangerous for us.
And very corrosive to the arteries.
And corrosive meaning that it corrodes, just like rust corrodes a pipe. It breaks it down and destroys it.
And this is all what's considered a pre-diabetic condition. So this is setting someone up for potentially having diabetes unless they reverse this course.
Okay, now the other question I asked that I'd like you to answer is, what causes triglycerides to elevate?
Yeah, good question. So triglycerides are an indication of fat in the blood. So oftentimes people think, well, let's cut fat out of the diet and that'll lower it. But what we find is actually cutting down sugar and starch is a much better way of lowering triglycerides than actually focusing on fats. So this sets into motion the questions of diets. And again, you know, if triglycerides are producing small, dense LDL, which are the most problematic type of LDL, what sort of diet's going to best control that is going to be more of a low starch, low sugar, what we call a low glycemic diet, even more than a low fat diet. Yes. So when we see folks with elevated triglycerides, that's the first dietary intervention we'll make, is to have them minimize sugars and starches.
And in a little bit later in this interview, we're going to talk about lifestyle changes, and, you know, one man's food can be another man's poison. So diets can be very bioidentical to you as an individual, and we have some great ways that we use at the clinic to find out what's the best bioavailable diet for you genetically, and we'll talk about that. Okay, so we talked a lot about a lot of the different markers, and one that we didn't touch on, and I'm gonna let you guys expound on it, is homocysteine. Explain why that's an important marker and what it tells us.
So homocysteine is a protein. It's involved in a metabolic process in the body called methylation, which is an incredibly important metabolic process. And when we see an elevated homocysteine, it's an indication to us that, how I describe it, is the assembly lines backing up in the methylation cycle. So it's a really good marker for getting a sense of whether we're methylating, but independent of the whole methylation issue is the fact that it's extremely oxidative, extremely inflammatory to arteries. So when we see an elevated homocysteine level, that's an independent risk factor for coronary artery disease, and it's important that we lower it. It's one of the tests we routinely run with folks. And typically the ways we lower it is by using nutrients that are methyl donors that help to lower homocysteine levels, and those are typically B vitamins, in particular B6, folate, and B12 are the main ones.
Okay, so just to help the average person watching this, he used a word that you may not know, methylation cycle, and correct me if I'm wrong, but it's just a term that explains our detoxification pathways. It's a cycle which has to be functioning correctly so that we break things down into water solubles, that we create enzymes that our body needs to function, and it makes this whole cycle work correctly. Is that?
That's one aspect of methylation. It's definitely involved in phase 2 detox pathways, but it's also really involved in neurotransmitter production, which are the chemicals in the brain like serotonin, dopamine, GABA. And it's also involved in DNA replication. So it has many. It's a very, very important metabolic function in the body. And
we'll do an interview on that at another time, because that's a whole other big topic. But it's an important one. Okay, so then I wanted to ask you: are there any other markers that you feel should be considered when assessing heart disease that we haven't already touched on? Anything that the public here would want to know?
Well, as I mentioned before, there's two particles that are what we call good particles. One is HDL, and the other one is ApoA1. And so those are ones that you want to actually see be in higher numbers so that they're more protective. So there's those, and then there's one called MPO, which is myeloperoxidase, and that's a sort of an indirect read on inflammatory processes in the cardiovascular system, and so that's also been well correlated with cardiovascular disease. And another one is called galactin-3. Now, MPO and galactin-3, and there's a lot of overlap with looking at cancer risk and heart disease risk, because a lot of the same markers are also markers when they're elevated with cardiovascular disease, are also something that you commonly see elevated with cancer patients. And this is just because many of the inflammatory pathways that develop a multitude of diseases, such as cancer and heart disease, share similar pathways. So that's, matter of fact, a lot of the patients that we see here who have cancer, we're actually running some of the same markers, not the cholesterol markers, but things like galactin-3 and MPO, for instance. But so those are some of the other markers. Is there any other ones? LP-PLA2?
Yeah, LP-PLA2 is really, really important because it gives us specifically inflammation in the arteries. We're going to want to look at other inflammatory markers, highly sensitive C-reactive protein,
Right.
Which gives us information about...
and then fibrinogen would be another important one.
Fibrinogen is another one that gives us information about inflammation and blood viscosity. The hs-CRP is a really important inflammatory marker. It doesn't tell us specifically where the inflammation is, but it tells us there's inflammation in the body. And if there's any sort of arterial disease or a high risk for it, we want to make sure that level is optimized. Optimal for that is typically under 1. Vitamin D is a really important marker for cardiac health and for a slew of other things. Checking thyroid function is really, really important for lipid metabolism. So this isn't talked about very much, and we do when we test thyroid here, we tend not to just test TSH, which is what's oftentimes tested routinely. We also want to look at the thyroid hormones, the free hormones, what are called the free fractions, T3, T4. We'll also look at something called reverse T3. We'll oftentimes look at thyroid antibodies. But thyroid's really, really important for clearing cholesterol, and it's something that oftentimes clinicians miss. They'll go after statins or even nutritional products that lower cholesterol, but sometimes what we got to do is optimize the thyroid, because when we optimize the thyroid, that helps to pull out excess LDL out of circulation. The other really, really important marker that we can run here is oxidized LDL. So we're actually able to assess whether that LDL is oxidized. If it is, that's screaming at us, and that's a huge problem, and we want to know that.
Okay, so I want to say a couple things. The common word I heard over and over is inflammation, inflammation, inflammation. So inflammation is the root of all disease. And the nice thing is at the clinic, we're going to help you know if you're experiencing inflammation, even though you may not feel it, and how to reduce inflammation or keep inflammation away. And then the other thing I wanted to let you know is fibroid is a big issue. It's a very misunderstood issue. It's an important issue. We will do an interview with one of our practitioners here, our naturopaths, who is very well educated and understands thyroid function really well. So look for that one coming up. Okay, so
another important marker we forgot about: blood sugar markers. So blood sugar, as we talked about insulin resistance, we get some information from looking at triglycerides. We get some information from looking at the ratio of HDL to triglycerides. But we certainly want to run what's called a hemoglobin A1C, which is a 3-month average of blood sugar. And then we have some much more sophisticated tests we can utilize for beta cell receptivity and for insulin resistance if we need to go that direction.
Okay, great. I did want to touch base on what things cause endothelial dysfunction, because that's a big word. People probably don't even know what that means, so please explain what that is. And then what things cause the dysfunction.
So all the vessels in the body have a 1 cell thick, which means a super fine layer of cells, living cells, that line the vessels. And that's called the endothelium. And so because it's so thin, it's also very fragile. And one of the things that people don't, that you don't natively think about, people don't realize, your heart's beating constantly, but your heart is pumping blood through those arteries and veins at a very high velocity. And in that high velocity, that means, and yet the other thing you have to remember is that all of those vessels bifurcate, meaning they spread, they split and then branch into many different directions. And they also change sizes. So it starts, from the heart, the vena cava and the arteries and the veins are very large bore. They're very large in size. But then they rapidly diminish to much smaller sizes. And one of the things that people don't realize is because the heart is such a strong muscle, the blood velocity that's going through those vessels causes an incredible amount of turbulence. And that turbulence is mostly focused at the bifurcations, the area where the blood is spreading out and dividing out. And so those areas, the bifurcations, are often very fragile because there's so much turbulence in those areas. And when you have things like homocysteine, when you have things like excess blood fats and plaque development, that endothelial layer can either be, some of those particles can actually get underneath the layer between the vessel and endothelial lining, or can actually damage the endothelium itself and then cause breaking off of what they call plaques or atherosclerotic plaques. So that's one way of looking at the endothelium and its importance.
Yeah. I think that's a great definition for people. That's a good visual for us. So what causes damage to that?
Yeah, smoking, obesity, hypertension.
Hypertension meaning?
High blood pressure.
High blood pressure.
Yeah. Inflammation. Heavy metals. Heavy metals can cause endothelial dysfunction. Exposure to chemicals, exposure to toxins, stress can cause endothelial dysfunction. And one thing I want to add about this is really the base of what causes coronary artery disease. So the old theory was that we ate too much cholesterol and cholesterol deposits in the arteries, and that's what the problem was. Cholesterol is actually a reaction to having this endothelial damage, which is almost like a little scratch in the endothelial. So the body responds by sending cholesterol there, by sending immune mediators there, like macrophages and monocytes. Those turn into what are called foam cells. It creates a fibrous cap over the whole thing. And it's what Mark Houston, who's a really great integrative cardiologist, refers to as a toxic brew. And if that fibrous cap weakens, which can have inflammation, helps to weaken it, it breaks off, that toxic brew gets exposed to the bloodstream, that's when we run ourselves into trouble.
So really, that's where lifestyle changes, coming to see me as the nutritionist, working with the doctors and the practitioners here to help people learn how to manage their stress. You know, we can't always change the stressful things that come our way, but there are so many great ways to manage how you respond to stress, and we do teach those things. Diet and exercise, getting that dialed in so that you can prevent endothelial dysfunction. Quitting smoking, we have great homeopathy. I mean, just quickly, if somebody wants to quit smoking, it is a hard addiction to quit. But it's an important one to quit if you want to reduce your risk of heart disease. And so we have homeopathy, which is great for helping people lose the sensation of smoking. So there's just lots of different options at the clinic to help in the lifestyle area of preventing endothelial dysfunction. Now, one quick question. If somebody does have endothelial dysfunction, are they no hope, or is there ways to reverse and repair endothelial dysfunction?
I think it's kind of comes back to what I was saying earlier, is that we use all these different tools, these testing formats, as a way to first develop a baseline, but also to determine, you know, people's risk factors and their level of risk at that time of the visit. But we also use those to confirm that the patient is actually healing. So it's not just a bunch of numbers. If you see Lp(PLA2) is elevated, which again is something that gives us a direct read on atherosclerotic plaque development, if you start to see that decline, that means also plaque development is declining. If we do an ultrasound Doppler and there's some evidence of plaque development, and the next time we repeat it, you can see less and less, that's showing that the endothelial areas are healing, in fact. And then the other thing is there are many science-based treatments that have been shown to actually help to heal the endothelial lining. And these have to do with a lot of antioxidants, a lot of the berries like blueberries and what are some of the other?
Phenolic compounds, green tea,
Green tea,
curcumin, dark berries.
Resveratrol is another one.
Yeah.
Those are all things that actually nourish and heal up the endothelial lining. So
They're rich in-
for sure, the body can heal that, but it needs some assistance.
Yeah, that nutrient is called anthocyanins. That's very healing to the arteries, and we get them a lot from dark berries.
So that's another reason why, working with practitioners at Heart of Wellness who understand those compounds, and sometimes it's not a matter of just drinking green tea or eating some blueberries. It may require that you need more concentrated levels, and that's where the herbs and the supplements will come in. So we utilize those here in a very effective way. Okay, so now just quickly, because we've mentioned it a few times, can you explain the carotid scan that we do and how somebody might be able to get it, how we use it and utilize it here at the clinic?
Yeah, sure. So we work with a lab that does carotid ultrasounds, and the idea behind that is by looking at the carotid artery, we can infer what's going on in the cardiac arteries, and there's a correlation of over 95% between the carotid arteries and the coronary arteries. And so we can do testing to see lipids and to look at inflammation and to look at oxidation and oxidative LDL. And those are great tests and very, very useful, but they don't actually tell us if there's plaque in the arteries. And if plaque in the arteries is what causes coronary artery disease. So the only way to really tell if there's plaque in the arteries is to look, and this is our best way of looking. The lab that we do this with also does another test called an IMT, or intima media thickness test, and that's looking at the thickness between the intima and the media, which are components of the artery that Dr. Tim talked about already. And that gives us information about inflammation in the arteries, and we actually come up with something called an arterial age.
Okay, to kind of wrap this up, this interview up, let's talk about dietary or lifestyle changes that we can do to prevent heart disease, and if someone finds out that they do have risk of coronary disease, heart disease, what can they do to reverse it?
So one of the first things that underlies the bulk of cardiovascular risk, it has to do with insulin management. And we talked a little bit about triglyceride production and insulin resistance. Didn't we talk about that?
Yes.
Okay. So one of the key players, the best, strongest medicine against insulin resistance, and despite all the sort of hype around it, is exercise is one thing that upregulates or increases metabolic rate at all the cells. And so that means if they've been storing glucose, that means now they can actually spit it back out or actually metabolize it and break it down, so that now they are again repositories for new blood sugar that needs to be buffered so that you can bring your blood sugar back into a normal range. There's no drug, there's no treatment, there's no medicine that has anywhere near the efficacy in bringing down insulin resistance that exercise does. And it doesn't mean that somebody has to do this incredible amount of working out or running or all this other stuff. Just walking, regularly walking on a consistent basis will bring down insulin resistance. And so that's just a clear example of a simple, natural thing that we're genetically predisposed towards, that our body can use to optimize our metabolic rate. And we'll definitely have an improvement, or you'll see an improvement with cardiovascular function and the markers as well.
Yeah, I think it's safe to say also that in almost all cases, the primary dietary intervention should be to make sure that we're on a low glycemic diet. For the reasons that Dr. Tim mentioned, but also because the small dense particles, and the other lipid particles mostly respond to a lower glycemic diet than they do to a low fat diet. In some cases, we want to put folks on a low saturated fat diet as well, but that's the minority of the cases. So LDL will decrease with a low saturated fat diet, but that usually doesn't change the particle sizes, and it doesn't affect it usually affects the bigger LDL, which are less problematic. Now, in some specific types, and we have a few genetic tests that we run here at the clinic, we'll get information that someone will do better on a low saturated fat diet. One of those is called apolipoprotein E, and that test gives us 3 variants that can come back. And if someone comes back with an apolipoprotein E or an ApoE4, they have a much higher risk of not only Alzheimer's disease, but cardiovascular disease, and they tend to do better on a low saturated fat diet. So that's one marker that we'll find where we'll integrate a low saturated fat diet in with a low glycemic diet.
It's very uncommon.
Right.
And then the other one is 3-4, which is about 25% of the population.
Right.
So that's more common.
And with that, with a 3-4, I typically would recommend a low saturated fat diet too.
Yeah.
Now again, we come back to that we have ways of monitoring these metrics by, you can put people on a diet and then see how they're doing the next time you test to get a sense of if it's the right diet or not. So we have tools in place that we can assess what we're recommending. The other test that we use in the clinic is something called pathway genomics, and they're looking at a whole bunch of genetic markers via saliva or blood, and they'll come back with a report that says whether, based on your genes, you optimally should be on a low carb, a low fat, Mediterranean diet, or balanced diet. So if someone comes back that they should be on a low fat diet, then we're probably going to gear them in that direction. Whereas if someone comes back they should be on a low carb diet, then something like a paleo diet is probably a really good thing for them.
And that's where, me as the nutritionist working with the doctors, it's a really wonderful balance, because we're all on the same page. Doctors are looking at labs and the results of very accurate tests, and then we can collaboratively find the best lifestyle changes appropriate to help somebody prevent heart disease, reverse heart disease. And so when you come to Heart of Wellness, you're getting lifestyle medicine. You are going to get great tests, very knowledgeable doctors, other modalities that will help manage stress, and then you get to work with myself and the doctors, where we're going to help you see what is the best form of exercise for you, what is the best diet for you, and you'll get really good results that are measurable.
Yeah.
So you get to see the results.
We really try to customize care. There's no one size fits all that we'll do here.
So thank you. I hope this interview was informative, and I hope it gave you some takeaways that you can think about. And please, we would love to see you. We give 15-minute free consults, so you can call our office at 360-570-0401, or you can go to our website at heartofwellness.org and read the bios on all the practitioners here, and come check us out. Thanks for tuning in.